My name is Dr. Alison Chiu. I'm a cataract and refractive surgeon from Sydney, Australia. Thank you for coming. I'm excited to share with you today the results of a pilot study on a new extended depth of focus lens, the Elon IOL, which is now available with prosthesis listing for both the toric and the non-toric versions. And this is the first international pilot study data that I'll be presenting today. So we're getting closer and closer to the holy grail of presbyopia correction. And we really do have a different patient population coming through. The world is changing. And these patients have different expectations. This is what 50 or 60-year-olds looked like 30 years ago. And this is what they look like now. And also this. And moreover, in retirement, the baby boomers are living very active lifestyles. So we really need to level up to meet the demands and expectations of our patients. So let's jump into the study design of this pilot study. It's a retrospective investigation. I have done binocular implantation. I'm going to present the results of the first 44 eyes today. And I've used a toric IOL when needed, and that was in 66% of patients. And the post-operative evaluation includes 1 and 3 month data after surgery, and this data collection is ongoing to 12 months and includes visual acuity, so monocular and binocular, distance, intermediate and near, as well as distance-corrected intermediate and near, as well as unaided. It also includes defocus curve testing, so visual acuity and contrast sensitivity, as well as residual refraction and visual function and patient-reported outcome measures, including patient satisfaction. So I want to take a moment to talk about the IOL features. It's a single-piece preloaded IOL, which is hydrophobic and aspheric. And it has a UV blocker and blue light filter, and this gives it a very mild yellow tint. And with this, I also want to discuss the ABI number because this comes into play, and it has the highest ABI number available on the market. And the ABI number is a measure of the chromatic dispersion or chromatic aberration that you get. And so this has very low chromatic aberration. And when we have lenses with very dense yellow filters, it's mainly because there's a low ABI number, a lot of chromatic dispersion, and that very dense yellow filter will cut off the whole blue and violet end of the light spectrum. So patients are losing that part of the light spectrum. It has a double C-loop haptic, so it's very rotationally stable. And it also is neutrally, so it has no positive or negative spherical aberration. It's neutral. So I will routinely look at corneal spherical aberration when I'm implanting lenses into my patients, but you don't have to worry about inducing or overcorrecting positive or negative with this lens. This is a range of the implanted IOL powers and SIL powers, which is to be expected. Most SIL powers are at the lower end. And so now I would like to discuss the results. So the post-operative is in the pink. I have 100% of patients within plus or minus 0.5 diopters post-operatively, with a range pre-operatively. In the far distance, 89% of patients see 20/20 or logMAR 0 or better, and 100% of patients see 20/25 or better, and that's for the distance corrected. For the binocular, and that's monocular results for distance, and the binocular results for intermediate and near are even more compelling, and these are distance corrected. So if you're using these EDOF lenses, and this lens in particular, in a mini monovision configuration, then the intermediate and near results are stronger. But distance corrected binocularly, 77% of patients see N10 or better, and 100% see N12 or better for intermediate, and for near, 75% see N10 or better, and 94% see N12 or better, with all patients seeing N14 or better. So we know that with EDOFs, the near results can be a bit variable across the board of all the technologies that we have available. But I like to pull out the vision chart and show patients where the minimum is that I think I'll get them. The defocus curve testing, I've got monocular and binocular defocus curve testing, and we have a peak at minus 0.50. And at logMAR 0, we have plain 0.66 and better than 6.6 at minus 0.5. And logMAR 0 at minus 1, that's 6.6. And logMAR 0.1 at minus 1.5, and then it starts to drop off. But at minus 2, it's still at logMAR 0.2. So there is a new classification of EDOFs that was launched at ESCRS this year, and that will come through. But this really is a true EDOF with 2 diopters of range. The post-operative refractive cylinder, 93% of patients fell within plus or minus 0.5, and 100% of patients fell within plus 1. So in terms of astigmatism correction, not specific to this pilot study, but the results were good. And what I would like to say is don't be afraid to flip the cylinder. It's not like spectacle correction. And implant the IOL that leaves the least amount of residual sil. There's no prismatic effect like there is in spectacles. And correcting the cylinder is very important in these sort of premium type lenses. The EDOFs, of course, are more forgiving, but with the multifocal IOLs, it is really crucial. In terms of the patient-reported outcome measures, the majority of patients could perform their usual daily activities without or with only minor difficulties, and 92% of patients were completely or very satisfied with their present vision. And in 44 eyes, this represents one patient that was an outlier, and 92% never required spectacles for far and intermediate activities. 54% of patients were completely or very satisfied with their near vision without glasses or contact lenses, despite the near vision not being an expectation of EDOFs. And it's a real-life situation where there is one outlier and probably the expectations weren't managed adequately by me. So the take-home messages are the Elon EDOF from Medicontur provides excellent results for distance, intermediate and near, despite that not being an expectation. But I would still tell my patients to expect to need reading glasses. But using it in a mini monovision configuration, you really can obviate the need for reading glasses for N6 to N8 or larger. It has a wide defocus range with sharp vision regardless of the viewing distance, and a high level of patient satisfaction and a low level of visual disturbances, which were uncommonly experienced and certainly not bothersome to patients. And as mentioned, I recommend to leave the least residual astigmatism and flip the sil if needed. And what I also found from the data collection was, though it's common practice at 1 month to refer our patients to the optometrist for, say, reading glasses, that it really did take 3 months to settle. And I think that this fits with the anecdotal experience that we also have from multifocal IOLs as well as other EDOFs. Thank you.